Hello, everyone, and welcome to CancerSpeak, the official podcast of Cancer, a journal of the American Cancer Society. I'm Dr. Linda Duska, the host of today's episode. I serve on the editorial board of the journal Cancer, and I'm also a gynecologic oncologist and professor at the University of Virginia School of Medicine. I'm really excited to be joined today by Dr. Melissa Lumish and Dr. Bill Tu to talk about their latest publication in Cancer that describes top advances in ovarian cancer that occurred in the past year. Dr. Lumish, Dr. Tu, thank you so much for joining us today on CancerSpeak.
To the entire team at the Journal of Cancer, thank you for this invitation for us to review our paper on the top advances of the year in ovarian cancer. Just to briefly introduce myself, I'm a GYN medical oncologist at Memorial Sloan Kettering Cancer Center in New York, where I am an attending and a clinical director of the GYN medical oncology service. I just celebrated this year 20 years at MSK, so that's a big milestone for me. I've focused my research on ovarian cancer and advances in all gynecologic cancer, but particular focus on treating older adults with cancer, and have worked on assessments and guidelines to improve the care of our older adults. I'm also very active in ASCO and their guideline committee.
Dr. Lumish?
Thank you so much for having me. It's great to be here. I am also a medical oncologist. I did my training at Memorial Sloan Kettering and worked there in the gynecologic oncology service. And I'm actually now an assistant professor at Case Western Reserve University and University Hospitals in Ohio. And my research focuses on novel uses of immunotherapy in the neoadjuvant and adjuvant setting across cancer types and in treating actually younger adults with cancer.
We're also really fortunate today to have an amazing and experienced research advocate, Annie Ellis, who is also a personal ovarian cancer survivor. Annie, thank you so much for being with us today and sharing your wisdom and thoughts with us.
Thank you, everyone, so much for including the patient perspective in this very exciting discussion today. I am soon to be a 20-year survivor of recurrent ovarian cancer. After 5 lines of treatment, 3 debulking surgeries, the last was a partial liver resection, and a phase 1 remission vaccine clinical trial. I've been serving the ovarian cancer community as a research advocate for about 15 years, and I have brought patient perspective to research discussions at NCI, FDA, ASCO, the SGO, and the Ovarian Cancer Research Alliance, as well as various grant review committees. I also provide peer support with patients at treatment decision points.
Annie, thank you so much for everything that you do. It's really important. It cannot be overvalued, what you do. It's really great that you can be here with us today. And to put the amazing things that happened this year that we're going to talk about in the paper in context with respect to the patient perspective. So thank you so much for that. So I'm going to give Dr. Lumish and Dr. Tu a little bit of an assignment here and ask you to share a quick summary of your article for those who have not yet had a chance to read it. What are the big points that you want to make?
Yeah, sure. So to be fair, we started this article in early 2023, and our first goal was to look at 2022. But as the year went on, so much has changed and developed in the field that we took our time and developed a paper that really stretches over about 18 months of advances. And there has been really amazing results in that time frame. I think the most important has been the continued success of PARP inhibitors for the use of women with ovarian cancer, particularly in the first-line maintenance setting. We also wanted to describe the new antidrug conjugate, mirvetuximab, which is the first FDA-approved drug in the setting of platinum-resistant ovarian cancer in well over a decade. So a huge development. And then we also researched and reported on all the literature discussing both the positive results as well as those trials that didn't meet its endpoints, but is important to understand as we start to develop future trials.
I'm really glad you brought that up. I think we have as much to learn about negative trials as positive trials in some cases, because hopefully if you learn from your negative trials, you stop going down that pathway, right? Or you learn something valuable in that experience. And it's so important to publish them. And we sometimes don't even talk about them. I noticed that in your paper, and I was really glad that you all discussed that. Not as sexy and exciting, but definitely important, right?
Yeah. And as a researcher, a negative trial informs us on how to develop the next study. And I think mirvetuximab is a great example of that. There have been multiple studies with antidrug conjugates in women with recurrent ovarian cancer, many of them, quote unquote, negative studies. drugs, but they informed us and we were able to develop a proper assay and really determine which population would benefit most by targeting the drug to that population.
Dr. Lumish, can you tell us a little bit more about the antibody-drug conjugates, mirvetuximab in particular, but then the space moving forward and what we have to look forward to?
Absolutely. So antibody-drug conjugates are a relatively new class of molecules. And what's unique about this is that we've used antibody drugs in cancer treatment and we've used chemotherapy, but this is a novel way to combine the two. So you have an antibody linked to a chemotherapy agent, and the idea is that the antibody delivers that chemo directly to cancer cells that have a specific marker on them. So in this case, the drug is targeting a type of folate receptor on the surface of the cancer cells, and it really works best in those who have a very high expression. So more than 75% of the cancer cells actually have this marker on it. And the idea, as I was saying, is that the antibody drug conjugate carries the drug to those cells, and then the drug gets released and actually affects both the cells that have the marker on them and also the surrounding cancer cells that may have a lower expression of the marker. So these have really gained increasing traction in the last several years because the targeted effect allows the drugs to be a bit more tolerable for patients with a slightly different but generally lower side effect profile. And that was really highlighted in the recent study that came out in the New England Journal of Medicine comparing mirvetuximab, this new antibody drug conjugate, to chemotherapy. And not only did it prolong the amount of time patients were able to remain in remission, but it also had fewer serious adverse events, meaning patients had less serious side effects from the drug. And what's interesting, kind of highlighting this point, is that as we were discussing, focusing on the negative studies that have come out in the past year also is a bit enlightening. So there was an antibody targeted at the folate receptor, not linked to a drug. And that agent by itself, even adding chemotherapy alongside it as a separate drug, did not improve outcomes for patients. So I think this is a really exciting time when we have the technology to kind of target the way that we deliver chemotherapy to cancer cells.
So adverse events are the way we providers or MDs or whatever you want to call us think about how to measure patients' tolerability and experience. But another better way we know is to do PROs or patient-reported outcomes and quality of life data. And actually, I know you both know that the quality of life data for mirvetuximab was presented. I don't believe it's been published, but it was presented at a meeting fairly recently, and the results look good. And my question to Annie is, whether we do PROs or adverse events, I think it's really, really important that we do that, and maybe that we actually report quality of life in the first manuscript rather than later manuscripts, but that's a separate issue. Do you think that these measures accurately reflect the patient experience, particularly with mirvetuximab, which has this novel eye-related toxicity that, at least in my anecdotal clinical experience, seems to bother people more than you would expect from looking at these data that have presented? So share with me your thoughts about that, and how can we learn more about the patient experience here?
I'm so glad you asked about quality of life and the patient experience, because the patient community is really excited to have a drug approved for platinum-resistant cancer that carries the folate receptor alpha. I'm also really excited by the possibilities of the whole class of antibody drug conjugates and delivering different therapeutics with different targeted vehicles. And hopefully that will help a lot of people down the road with more research. We are concerned with some of the side effects, and I think how we collect that data is really important. With PROs, there's the opportunity to collect more of this information in real time instead of every 3 weeks or whatever that interval is when you see the doctor, and the doctor determines what side effects are more bothersome and then gives it a number and then decides whether or not to report. For myself, in the moment, I'm more likely to report something if I have it anonymously. And when you're at the appointment, you might not remember. So I really think that PROs are more accurate and the way to go. I know sometimes it's hard to get the funding for that, but I'm really excited that people are working these more into the trials. And I think earlier is better to get an idea of what it's going to be like for a patient to live on certain therapies. Some of these targeted therapies we're going to be on for a very long time. And the sooner we have that information, the better. We're hearing also in our community a little bit more about the gastro effects with MIRV, that we see a lot of people not being able to complete or stay on treatment. You know, the eye issues, that is troubling too. But what we're hearing in support groups is that people are having trouble with gastrointestinal issues. And we really didn't see a lot of that in the research, and that was reported out.
I think what's really important, and I'd be interested in Bill and Melissa's thoughts about this as well, the PROs and the experience of individuals on a clinical trial are not going to be the same as individuals in real life. I'm doing quotes around real life. You can't see it, but I'm doing it in my head because those patients that enter clinical trials are a different population, as we know, because it's a very restricted population with a very good performance status. And so I think when we talk about the patient experience after the clinical trial, we have to be mindful of that. And your point is very well taken. You're going to see different toxicities in the clinic in the patient that's in your office who maybe doesn't have a performance status of 0 or 1 than you're going to see on a clinical trial. Bill or Melissa, I'm really interested in your thoughts about that.
Yeah, no, I totally agree. And I appreciate what Annie said. Just to rewind, this is a new drug for us in this community, patients and providers with very unique toxicities. It got FDA accelerated approval 1 year ago, about 1 year ago, December 2022. And we actually didn't start using it in our clinics for several more months because of the lack of availability of the folate receptor assay. And then it's been a learning process. Here at MSK, we've used the drug in clinical trials, but I know many centers, it was their first time using this drug and experiencing the supportive measures, particularly for the eye toxicity. The other one that we see is neuropathy. We're seeing neuropathy, particularly in someone who's had prior taxanes. But I would say as the year has gone on, from both physician, APP, nursing perspective, our experience and comfort with using this drug has significantly improved. And stressing and teaching proper eye care with the drops. And we've developed close relationships with not only the ophthalmology team at our center, but also local providers, because it's such a critical part of prevention of eye toxicity. And we're a strong believer in all the patient education forums, as well as the ophthalmology forum that can be provided to local providers so that they know what to look for.
I'm very excited about the patient education and all the effort that's gone into help manage and lower the risk of that happening, because it's just so important, but it's a wonderful thing to be able to do something to help not have a certain side effect.
Well, and as you guys talked about in your paper, there's new antibody drug conjugates, new linkers, new payloads, new antibodies coming down the pike. There's combinations, mirvetuximab plus and other drugs plus. So I'm really looking forward to your paper next year when you talk about all the amazing new opportunities to hear what's coming up in the next year or so, because it's a very exciting time in ovarian cancer. Before we run out of time, I want to move on to the PARP inhibitors, because we've had some confusing things happen this year with some FDA withdrawals, actually, for prior given indications. And I was wondering if one or the other of you would like to talk us through that and maybe summarize what the current recommendations are.
It has been a confusing year and a half because of both the evolving evidence that we have with PARP inhibitors, the withdrawal of indications of PARP inhibitors, and really trying to keep track of the where and which drugs are approved and indicated, because it can be quite confusing, to say the least. What we tried to do here, because this is still continuing to evolve, was really focus on what has been reported and really stress in Table 2 what are the current FDA approved indications, because it's much harder as we go into the details of the specific updates with each individual trial, because there is some controversy still. But I think the FDA approval and indications are very clear cut. What we wanted to stress, and I think this is most important, is that PARP inhibitors remain the biggest breakthrough in ovarian cancer over the last 2 decades since carboplatin and paclitaxel. Patients are living longer. They are higher rates of cure. We still have much more to do, particularly in those patients without a BRCA mutation or homologous repair deficiency score positive. But what we've seen over the last year and a half, particularly with the SOLO-1 update, was that there is now a clear overall survival benefit of the use of olaparib maintenance after 7 years of follow-up of the patients on that study. And this is again in the patients with BRCA mutation, the use of olaparib for 2 years extends overall survival. The other very reassuring piece from this update was that the rate of severe toxicity like myelodysplastic syndrome and acute myeloid leukemia remains low and rare. So that is the good news. And what we wanted to really stress is that many of the updates that were provided were from clinical trials from a long time ago. from very early in the development of PARP inhibitors. And this was primarily in patients with recurrent cancer, whether that was with measurable disease being used as treatment, or in the maintenance setting in the second or line greater recurrent maintenance setting. And as the first-line maintenance therapy trials were reported and indications obtained over the last years, the use of PARP inhibitors is clearly best in the first-line setting. And that's what we wanted to stress here and to summarize. And again, olaparib, whether on its own or in combined with bevacizumab, clearly with those patients with BRCA mutations, germline or somatic, in combination with bev in the HRD score population positive, and remains standard of care. And niraparib, for sure, in patients in that same population, BRCA mutation, HRD score positive. It also has indication for patients without BRCA or HRD score positive with lower benefit.
I heard a sound bite from you.
Yeah.
You said no question in the first line, BRCA positive. Soundbite, absolutely no question, right? Probably the HRD also.
Yes.
I heard you say that and I thought perfect soundbite. Really important point.
Yeah, exactly. I think this is sometimes you could get lost in the weeds. And to stress this, PARP inhibitors are a standard of care treatment that doing genetic testing and HRD testing early will help you make decisions with your patients on whether to provide PARP inhibitors as a maintenance strategy after first-line chemotherapy. And it should be where the focus is.
That was another soundbite. Every new ovarian cancer diagnosis woman or person with that diagnosis needs to be offered genetic counseling if available and genetic testing as well as somatic tumor testing.
And even in those patients that have negative BRCA status, really going the next step, which is tumor testing for homologous repair deficiency. And this can be a little bit more challenging because there's many companies that offer this score. We really try to focus on the diagnostic tests that have FDA approval. That's through Myriad and Foundation Medicine. But it is an important component of decision making, and we really wanted to stress that. I think the other areas that created all this confusion really were in the later lines in patients with recurrent disease and in the maintenance setting, second line or greater, again, seeing the benefit in the patients with BRCA. And those without BRCA or an HRD score positive, that's the areas that are losing the indication in the second and greater line maintenance setting. So again, stress, use PARP inhibitors, first line maintenance, genetic testing, HRD score testing early, and then you can use our papers for the references and some further details on how the story has evolved.
Dr. Lumish, anything you want to add to that? That was really extensive.
I think, the emphasis on the genetic testing, it does really, of course, I'm curious to hear Annie's thoughts as well. But in talking with patients, I found may or may not be hesitant to proceed with genetic testing. And I think this emphasis on the impact that it could potentially have on their own care, not just that it's an implication for family members, I think really is important to highlight in talking with patients. The other thing that I think been interesting about this is that sometimes less is more. And I think a lot of times when we have a finding like a BRCA mutation or HRD, our inclination as the providers and as patients is to try to include everything possible. And I think what we've really learned in reviewing this data is that there are specific scenarios where this is going to help, and then we may actually cause harm by offering a PARP inhibitor when it's really not been shown to help patients. And then the last thing that I thought was interesting that Bill has already really touched on, but was just a lot of patients also worry about what's the long-term harm of taking a medication over a long period of time after I've already finished my chemo and maybe they don't currently have active disease. So the finding that we can actually improve survival without really dramatically increasing risk of secondary malignancies, I think was also a really huge outcome here.
Annie, what do you think the key takeaway for patients with respect to PARP inhibitors should be from this paper?
I think the most important thing is for patients to make sure that they're learning from the cancer, right? And that's through the genetic and the somatic mutation testing, because that is going to help prioritize the options. And we want to have therapy that's going to give us the best result to maximize whatever benefit we're going to have. The upfront setting is where it's all about. having access to that and knowing who should get what and when. This is really what we've learned. It's been an exciting 18 months and longer. These options weren't available 20 years ago when I was diagnosed. And I think thanks to the doctors, the researchers, all the people who've participated in the clinical trials, we've come to a point where we're getting better at helping people have what's going to help them the most right up front.
PARP inhibitors are an amazing example of targeted therapy that works really well. But you have, to your point, you have to target it correctly and to the right population. And along those lines, let's take a few minutes, Dr. Lumish, to talk about immunotherapy, because you mentioned immunotherapy. And what are your thoughts about immunotherapy in ovarian cancer? Is there a future there?
Yeah, it's hard to say whether there truly is a future. I mean, I think within gynecologic cancers, there have been some major advances in the role of immunotherapy, particularly in endometrial cancer, where it's now approved in the first line and second line setting based on specific indications and combinations, and in cervical cancer. But with ovarian cancer, based on just the different disease biology, it really has not been shown to be beneficial. And I think looking broadly at the studies that have examined patients with mismatch repair deficiency, which is a specific genetic subtype that makes the cancers appear more abnormal and therefore more recognizable to the immune system, even in these cancers that don't normally respond to immunotherapy, there may be a role. But I think broadly for ovarian cancer at this moment, we haven't really seen it being effective. And it's not really entirely clear why that is. I think some of these cancers may be more immune protected and maybe just kind of have fewer abnormalities that aren't well recognized by the immune system. But at this moment in time, there's very little efficacy for immunotherapy, specifically meaning checkpoint inhibitors in ovarian cancer.
Anything else that was in your paper that we didn't touch on, or any other points that you want to make before we end?
Again, I appreciate everything Annie said and Dr. Lumish's insight here. When we're talking about ovarian cancer, we're really specifically talking about high-grade serous ovarian cancer, which is the most common type of ovarian cancer. And what we tried to highlight in the paper also was some of the smaller studies in the rarer types of ovarian cancer, particularly clear cell carcinoma and carcinosarcoma, two rare, very challenging types of ovarian cancer to offer effective treatments. So I think we've made great strides in patients with high-grade serous. Our hope is that we'd be able to focus on these rarer subtypes.
Yeah, good point. Annie, any words you want to add regarding the patient experience and what patients can learn from this?
I just want to piggyback on the IO disappointments that we've had. It's been extremely disappointing for our community not to see the responses that we see everybody else having in that space. It's like Harry met Sally. I want what they're having, right? And we just haven't gotten there. And I've served in research spaces where researchers and clinicians are just working extremely hard on IO strategies and combinations and making cold tumors hot, all these things. And I don't want people to stop trying. We deserve the robust and durable responses that are also tolerable that we're seeing in other cancer types. And so I think even though we've got a lot of great strides here, the work's not done. We want more. And I think we have enough people working out there that we can get there. And I thank you all for your work.
Yeah, that's really well said. And being in this field now for 2 decades, I think the point of never stop trying and learn from a negative trial, because that's where we will make differences. And there's still immunotherapy remains a very active area of research for women with ovarian cancer.
Well, I will date myself and tell you all that I was practicing before paclitaxel was FDA approved, when we were still doing a randomized trial of cyclophosphamide plus cisplat versus paclitaxel plus cisplat. I am forever grateful to all of the individuals who agree to go on clinical trials, because we owe to all of them the advances that we have made. And so I just want to take this opportunity to thank them. And I'm a cancer researcher. I would like to thank my research team, because I'm sure you guys would agree, without our research teams, the regulatory people and clinical research coordinators and our research nurses, none of this would be possible. So they're in the background and they never get thanked, but I think we should thank them too. And thank the both of you for the really lovely summary of a tremendous year in ovarian cancer. It's a really great paper. That's all the time we have for this episode of CancerSpeak. Thank you to Dr. Lumish, Dr. Tu, and Annie Ellis for taking the time out of their very busy schedules to join us today. And a special thank you to our listeners who tuned into this episode. I encourage you all to read Top Advances of the Year Ovarian Cancer, now available in Cancer. And as Dr. Tu noted, there are references in there that will help you find the guidelines for PARP inhibitors. We will include a link to the report in the show notes. Thank you again.